So cleft lip and palate is probably the second most common birth anomaly, and it occurs 1 in every 700 live births. We see quite a lot of infants here at Johns Hopkins Children's Center. My partner, Dr. Rick Redette, and myself see a lot of babies that come in with the cleft lip and palate. They do have an initial surgery that we perform in infancy to correct the lip as well as the palate. The palate is the functional part, of course, that is related to speech production and is very important. These surgeries are then followed up years later by some other additional procedures to help the development of their bite with their dental development as well as their facial skeletal development. So cleft lip and palate, the initial repairs are performed in infancy as we talked about, and then we will watch the children as they grow to evaluate the dental and skeletal relationships. Typically, because of the condition itself, as well as some scar tissue created by the early surgeries in infancy, the upper jaw will not grow at the same rate as the lower jaw, and we end up getting what we call a class 3 bite. That class 3 bite, when the patient has reached what we call skeletal maturity, usually 17 or 18 in boys or 16, 17 in girls, will need to be addressed with surgery because it cannot be corrected with orthodontic work alone. So when the patients have reached those later teenage years, we have a discussion about doing the jaw surgery, and then to allow the orthodontist to achieve that final result and bring the teeth as well as the facial skeleton into harmony. So jaw surgery is certainly one of my specialties here at Johns Hopkins, and we do have a lot of discussions ahead of time about what to expect with such a large procedure. The patients are counseled that this is a procedure that's often done over a holiday break or over a summer break. They need to have generally 2 weeks off from school. There's a fair amount of swelling to be expected with the procedure, and then some rehabilitation in terms of wearing some rubber bands to get the teeth into the new position, as well as adjusting with the diet during that period of jaw healing. Generally, it's a very rewarding procedure. It can make a very nice change, and oftentimes can be the last hurrah for our patients with cleft lip and palate before they then head off to college. So many patients who have this class 3 bite or anomalies of the facial skeletal proportions will have these difficulties with their psychosocial adjustment, and that's one of the things that we talk to them about. The surgery has benefits not only of improving their overall psyche and functioning, but also in providing proper occlusion and allowing them to chew certain foods that they may not have been able to do before. So there's both an oral functioning component as well as an overall psychosocial component that can make a very large difference for them. So at Johns Hopkins, we do see patients both with cleft-related jaw anomalies that require surgery, as well as other children who may have disproportions of the jaws that require the same surgery but for different diagnoses. And sometimes there is no other underlying diagnosis aside from the fact that there's a class 3 bite that develops for other independent reasons. So we do take care of patients without cleft lip and palate who have a similar issue and can get them very successfully through this procedure as well. So jaw surgery can be performed by several different types of specialists, including oral and maxillofacial surgeons as well as plastic surgeons. One of our unique approaches in plastic surgery to jaw anomalies is that we're looking at the whole patient and can address both the aesthetic qualities as well as the dental relationships. So we're really seeking to bring into harmony the facial skeletal balance as well as the abnormal bite. And again, in plastic surgery, that's one of our focuses to deliver not only a result which is good functionally, but also makes the patient feel good about himself or herself. And again, this is a team effort, so I couldn't do this work here at Hopkins without the work of my colleagues, not only our surgical colleagues, but also our partners from dental, orthodontics, speech therapy, etc. Johns Hopkins Children's Center has some unique advantages to provide to our patients with cleft and craniofacial anomalies. We take care of our patients in multidisciplinary clinics, and this is typically an opportunity for a patient and his or her family to see as many as 4 or 5 providers in the same day. This is efficiency for care, but also allowing them to hear sort of a well-organized plan that allows them to feel comfortable with what's being proposed. Dr. Rick Redette, my partner, and myself have a combined 20 years of experience in this field and are very happy to be able to serve the community for these kinds of conditions, and I'll call upon you to come see us if we can be of assistance to you. Thank you.